Hi, everybody. So we want to start a orthopedic oncology series of podcast or even video podcasts where we can discuss the practical aspects of orthopedic oncology for orthopedic oncosurgeons or orthopedic surgeons. Because many a times what we come across is a lot of complicated cases which would have been sorted out very easily. So in this series, I would like to cover on the pelvic tumors, pelvic bone tumors. So pelvic bone tumors has to be managed by a team. So once we get to know it is a pelvic bone tumor, you have to undergo a proper scanning. There is no shortcut for in 2024 or in today's world. There is no shortcut for substandard imaging. We have to have a great image in methodology. It could be not. It could be. It has to be a 3 Tesla MRI. It's like 1 mm slice thickness and a CT scan 0.6 mm thickness with a PET CT scan. Get these things done. Let's get a biopsy done. Once the diagnosis is confirmed, so let's go directly if it is an Ewing sarcoma or an osteosarcoma. It has to be uh, given a chemotherapy. That means neoadjuvant chemotherapy. What I mean to chemotherapy is the right chemotherapy. Many times the chemotherapy protocols are very, very varied and not very right. Because it has to be right, because we are talking about a curative intent of the whole management. When we are thinking on those grounds, the chemotherapy also has to be on the top of the line, proper chemotherapy. You cannot refer to me without the proper chemotherapy, please. That's very, very important. Once the chemotherapy is done, say we are planning for a surgery, so we start the planning for surgery much advanced. That means much before the surgical date. That could be at least a month prior. So what we do is we study the images in detail with the radiologist, with our team. Then we involve our engineering team, with 3D printing engineers, implant engineers, so that we have to have a R0 resection. That means the tumor has to be completely removed plus reconstructed. So complete removal of tumor in pelvis with with such a complex anatomy, such critical structures in the pelvis needs a very detailed discussion, detailed planning. For that, once we involve the 3D printing engineers, so we make a model, 1:1 model of the tumor. We print it out and we study that. After that, we do what is called as jigs, custom jigs. That means special 3D printed templates which make the bone cut in a specific pre-planned angle so that not extra or not less the bone is removed. That means an adequate amount of bone is removed around the tumor so that the tumor comes out in one piece. That's the most important thing. So that's called jig preparation. Once we prepare the jig, then how do we reconstruct? So pelvic reconstruction is a very, very difficult reconstruction because there are no standard implants, because there are no standard tumors, because the tumors, some tumors are small, some tumors are big, some tumors are inside, some tumors are outside, some tumors are involving many joints, some tumors are involving the nerves, vessels. So no two tumors are same. So we have to customize the implant, customize the planning individually for a patient. So in such a scenario, what we do is we have a plethora of implants which are over the counter available, which has been time tested, not in the pelvic tumors but hip reconstructions. So we use them, and we use a 3D printed implants. So we marry them. Also, off late we have designed our own Chinder's bioprosthetic method. So what we have done in that is we use a biology to make sure the bone unites and a 3D printed implant so that biology and the implant both have contribute to the reconstruction. Why not this old regular available implant? No, because the weight distribution of a leg of a weight of a body, so has to have pass through certain lines. So that for a child or for an adult, for anybody to be active, the pelvis has to transfer the weight of the body in a particular fashion. So with all these consideration, it has to be a bioprosthetic design. So we there are many methods considering your availability, because we have a lot of time to plan these things, say about a month and a half. So it is better to involve all the implant companies available, because many there are many companies which manufactures various parts, like building a, I would say, a Ferrari. Ferrari cannot be built alone by Ferrari guys. So it has to source a lot of parts from different world class part manufacturers. So I consider pelvic tumor or any orthopedic complex work is like a Ferrari, work of a very detailed, fine, planned work. You cannot do mass manufacturing work in this, because it takes time. Because I have seen, experienced both the ends. So with that, all this experience, I have come to a conclusion that even if it take time, even if it take a little more resources, we have to have a detailed planning for a beautiful outcome. So, what I mean by outcome? Outcome is not finishing surgery. Outcome is 2 years down the line how the child is walking, 5 years down the line how the adult or a child is working around or doing his day to day activities pain free. So, this is extremely important in pelvic tumor to consider a long term outcome. Not only pelvic tumor, all the tumors, but yeah, as we're discussing. So once we plan it out, it could be as simple as just removal of the tumor. You don't need a reconstruction in some cases. In some cases, you do need a reconstruction with the help of implants and biology. And once the plan is set, we print out a file of what are the stepwise planning. So this file contains every single step of what are the problems to be expected, also what are the solutions for that, and including we even make a note of what instruments to be used at what levels, because what happens is there are no standard instruments. There is many, we need all plethora of instruments, but if you spread them out in the theater, you need a 20 by 20 feet theater to spread out all the instruments, isn't it? So no, so because of the engineers help, because of our team help, we shortlist all the instruments, what are the things to be needed, including the blades, type of blade, type of saw, type of K wires, type of screws. And screw, as an orthopedic surgeon, many of you know that every screw box will have a like 1,000 screws. So no need to have them. Thanks to our 3D planning, we specifically measure what screw has to be kept. So we essentially keep about 10 screws to 15 screws. That's how it has to be planned. Because when you start removing the tumor and reconstructing, this will be your like 12th hour or 15th hour of surgery. So at that time you should not be searching for screws. So hence what we have done now is we even space out the surgery for 2 days. I'll come to that in a moment. So this is the planning we do, and we print out this data and in the paper. Also we print out the model and jigs and everything. We pack up everything and make a trial run on the previous day of surgery. We do a trial run, everything dry run, including the proper instruments. We do a dry run and make sure everything is set. Then on the day of the surgery, most pelvic tumors, see the literature. There are many literatures which has been, I would say, 80% of the literature says the major problem in pelvic tumors is blood loss. As I has like 4-5 liters of blood loss. This is the most dreaded complication of pelvic tumor, which we have been able to conquer, or we have been able to control the bleeding with various methods. Again, so we have a five pointers for that. So number one pointer is most pelvic tumors we do a preoperative embolization. Number two, most pelvic tumors we have to do a hypotensive anesthesia. Number three, usage of 3D printing or navigation surgeries, because it will really precision will be very high, so you are not meddling around things. And number four is usage of energy devices, the present day energy devices, that is harmonic scalpels, ligashores, bipolars. Like, they're superb energy devices nowadays, which we use them to make sure the bleeding is minimized, and most importantly, saving the blood from the word go. What I mean to say is, many of the surgeons is in the beginning, when their mind is fresh, and when you start the surgery, you're like boom boom boom, you just go on cutting it up, and you lose quite a lot of blood in the beginning itself. So no, so we have to save from the first neck. So I always tell my boys to minimize the blood loss much less than the anesthetist. I mean, just kidding. So many times, so we even count, I say, how many RBCs. That's the joke. So that if you have it in control, because most children are would have gone through chemotherapy, would have, so essentially the stress to the body is also pretty high when the surgery is prolonged. So that these are the five principles which we follow to minimize the blood loss. So once these things, preoperative embolization, take the patient in the theater as early in the morning as possible. We start pretty early. We do not keep any outpatient department on a pelvic tumor day, because the whole team has to be with us, because it is a difficult work, and everybody has to be involved in that. That's what we believe in it. So even the anesthesia team is the most important in pelvic tumor surgery. We have to appraise them, and thankfully our anesthesia team is fantastic, which really, uh, because if the people are not doing these surgeries regularly, even the anesthesia people cannot handle for more than 12, 13, 14 hours, 15 hours. So that's very, very important, anesthetist team. So secure the central line, epidurals, all the lines that itself take about 30, 40, 50 minutes. Position the patient. Most patients we put a floppy lateral so that patients can be turned in any angle they want. So that is most easiest and the best way what we have come to know. And catheterize the patient. Once it's done, sterile drape, umbilicus downwards, everything. Then set up the drape. I mean, uh, time out. We always do a 1 minute of prayer before doing any surgery. Prayer followed by, of course, on the background dish, good music. So once we started, we prefer to do the vascular work or the neurological work first, because when your hands are fresh, there will be no tremors. Because when you're doing it at the 8th hour or 9th hour, you may have some shivers in the hand. That's the microsurgical principles. I remember my NUS days. I was trained in Singapore National University Hospital. So I remember my boss, Professor Emmerich Lim or Mark, was telling that you're not supposed to go to gym or drink more coffee before a microsurgery work. So that's very, very important to make sure that your hands are not trembling. So once it's so you start dissecting the blood or the vascular work. So that part of the critical work, we dissect out at the groin, enter the pelvis, enter a part into the proximal thigh, so that your vessels are free and no, they are not in tension. So once it's done, we dissect out the femoral nerve very nicely, and femoral artery and femoral vein. So these three things are dissected out and looped using the vascular loops. So then we cut out the iliopsoas with it, and we mark them and stitch them for the future reconstruction. So once this is done, So we dissect out that part of it and come to the iliac side where we tease out the origins. Generally, we don't tease out the insertions. We tease out the origins with a margin of tumor and go to the sciatic notch. So in my earlier days, the sciatic notch was a big problem for me. So because the superior gluteal artery was and the other nerves was always causing trouble. But of late, we have come to know with the 3D printing help, if the sciatic notch is free, we can nicely push them downwards and free that area. Once all these dissections is done, we have to go back towards the posterior, go to the sacral area, create have a nice line of from top to bottom, dissect that out, and go to the abdominal side. You just have to push the things, vessels and the iliopsoas away, so it will just drop off very comfortably, extra peritoneally, no intraperitoneally. Sometimes we use a robot before the surgery. I particularly in sacral tumors. So on the previous day. So all these things I forgot to mention that we do this procedure on 2 days essentially. First day will be the dissection, the tumor dissection. The second day and the tumor resection. Second day will be reconstruction. In this way, what we have felt is we have reduced significant patient stress, surgeon stress, and infection levels are low, and the wound healing is high because the tissue would have gained certain amount of healing capacity. Also, the incision has to be planned well. So these are some of the things which we have to keep in mind. Once the dissection is done, we have to use the jigs, the 3D printed jigs to make sure the bones are cut in a proper fashion. So advantage of jigs is it will make sure your saw cuts the whole extent of the bone, because earlier when you were using osteotome, you would not know where some of the bones are not cut, and when if it is not cut, your pelvis wouldn't move at all. It will move, doesn't move a millimeter. So because pelvis is a very strong organ. So jig will make sure the end to end is cut in every angle, and all we have to do is release the sacrotuberous and sacrospinous ligament. If these two things are released, most of the pelvis will start moving out. So once this pelvis moves out of the once it starts wobbling. So another most difficult structure to release is issue in the pubis area is around the corpora cavernosa insertion, because it's a very vascular thing. And if there's no tumor, you can go on, keep your cautery onto the bone and tease it out. But if there's a tumor there, it's very, very deep. You need a help of a uro-oncologist. Definitely, there is no doubt about it, because urethra, corpora cavernosa, all those things are very, very close to the dissections. So, and the last and the most toughest part is the muscular origin of the ischium. That means all the hamstrings, which originates there, is a huge muscle chunk which needs to be. It's very difficult. Your hands will start paining, but with the help of radio energy devices, and if you protect that the sciatic nerve properly all the time, loop it down, so definitely you can save that. Uh, once this tumor comes out, so most of the time it would take a big tumor will take about 10 to 12 hours, 14 hours, depending upon the complexity. So we would not extend it on the same day. We would close the wound temporarily, shift the patient to ICU with minimal anesthesia support, sometimes off anesthesia. Next day we take the patient inside. In the interim, sometimes we even do an MRI to make sure that there's no tumor. The margins have been very well uh, removed. I mean, that's for our documentation and our academic purpose. And we get the uh, patient next day morning again. We start reconstructing. We use reconstruction, as I mentioned, with the help of it could be hemicone prosthesis with Lumic or a stand more or a custom made 3D printed. We 3D print many processes with our own in-house engineering team. So because ours is a team of orthopedic oncosurgeon and we have about 4 to 5 engineers and direct in our team and about another 4 5 engineers support from outside. So we communicate to and fro quite often and come out with very different customized implants standing on the principles of orthopedics. Uh, so once it's removed and once it's planned, reconstruction would take about 7 to 8 hours with nice. Because why? There are a lot of not just bone reconstruction, a lot of soft tissue reconstruction, which many of us neglect in the beginning days. But soft tissue reconstruction is the most important thing for the functionality. So all the muscles reconstruction, all the ligament reconstruction, if it's possible, has to be done. Then comes the most important, the closure of the abdomen. So we use our in our team, Dr. Prabhu, who's helped us in help evolving the closure of the abdomen, and Dr. Prashant is a plastic surgeon. So we separate the layers of the abdomen, so that it comes migrates properly, and the closure becomes better. Otherwise, it is very tight and usually end up in a wound infection. So after learning this principle, this has helped us in the wound closure better, uh, mobilizing the abdominal muscles and closing onto the. And also we use a new stratifix, that's the barbed sutures. So these barbed sutures help us not so quite fast, and it's I think not so traumatic to the tissues, what I felt. And we use mesh in the hip joint reconstructions and close the wound and take a x-ray picture then and there to make sure the fixation is good and stabilize and keep the hip in the proper position, check the drains, and shift the patient to the ICU for about a day or two depending upon the recovery period. So with these techniques, most of the pelvic tumors we have handled have a blood loss, say about 600, 800 or a liter of blood loss maximum. If we exceed more than 1.5 liters, we generally try to not to extend the surgical time. We stop it, do it next day, or we try to control every bit of bleeding before we give a stress to the patient. Post-surgery rehabilitation is extremely important. Because most of these children are post chemotherapy. They have very little healing capacity. So it takes time sometimes to heal up. So we use, if there is a difficulty in healing, we use a VAC. In the early days only we finish the VAC, make sure take help of plastic surgeon so that the wound part is quickly handled. We will not sit on it for the body to heal. No, we'll make sure then and there take them to the theater and close it up, take the help of plastic surgeon and finish it because they have to continue with the chemotherapy. So with these things, we are able to handle most of our pelvic tumors pretty in advanced way with most technology, including 3D printing, navigation. We are one of the first ones to use in India the striker navigation and robot. We have published a paper. It's there in the JBJS where when we can use a robot in sacral tumors and sometimes also thanks to the very advanced imaging, that means with good CT scan and MRI, we're able to get into this kind of work. So this involved, I don't know whether you understood, but there's all the team. Essentially, we have our orthopedic oncology. It's about 5 to 6 of us. A joint replacement surgeon sometimes, plastic surgeon, GI surgeon sometimes, uro-oncologist, and vascular surgeon, intervention radiologist, anesthetist, uro-oncologist. So this plethora of specialists, if only if they're with you, this your process is nice and you enjoy doing the pelvic surgery. Otherwise, most pelvic surgeries are not so enjoyable. But we thankfully thanks to our hospital system, our environment, our culture, where we all sync with each other and make sure the outcome is the one where we plan and go ahead. So that's about, I think that's about pelvic tumor surgeries, which I would target, or which I would feel that this has to be told or discussed with most of our junior surgeons, orthopedic oncosurgeons, or even some patients who may need to know information of what we do. So, yeah, I feel pelvic today in 2024, we have to have uh, all the technologies and the team to have the best outcome, and we have to get the best outcome come from wherever in the world they are. So it is better to join hands like how we have joined hands with various hospitals starting from Italy, Europe, to Netherlands. We meet a lot of doctors, friends, discuss cases across and plan it. Otherwise, we don't generally hop in and start planning it. So I would strongly advise all the uh, orthopedic surgeons who want to handle the orthopedic oncology work to have a conglomeration or to have a team of, and you should set up a place, like for example our hospital as a point of contact, so that you can start working, you all start working with each other, and to come to have a proper goal, because everybody in every hospital cannot have all these things what I have mentioned right now, because it's a very intensive people and technology oriented profession and technology. So it's very, very difficult because these are all deep specialities. What I say is you cannot have a Ferrari factories everywhere in the world. You have to have it in one place to make sure you get the right uh, uh, beautiful product at the end. Thank you.